Hi, everyone. I'm Dellann Elliott Mydland, President and CEO of the End Brain Cancer Initiative. And today I have the pleasure of getting to spend some time with Dr. Christian Grommes. He is a specialist in the disease known as PCNSL, which he will explain to us in full detail throughout this interview. So, I'm the president and the CEO of the End Brain Cancer Initiative, and our mission is to help patients with disease in the brain, with cancer in the brain and the central nervous system to receive the best care possible and to educate them about the necessities of considering a clinical trial and advanced diagnostics as part of their treatment options. So I am delighted to be here today. And now we would like to introduce Dr. Christian Grommes. And I want to tell you a little bit about him before he gets to talk, okay? He is a neuro-oncologist, an early drug development specialist at MSK in New York. I looked at his resume and you incredible work you are doing, incredible accomplishments, and your research and your publications from that research are vast. And I just want to say thank you to you because
Thanks.
truly, truly, you really have dedicated your life to research and to this disease as well. So thank you. We need more people, special people like you. Thank you.
Well, thank you.
But his areas of expertise are primary brain tumors, CNS lymphoma, central nervous system lymphoma, and brain metastases. So that means cancer disease that has spread to the brain. And again, we mentioned that one of his specialties is early drug development, which he'll explain what that means a little bit later. And one of the things I thought was really cool about him, he's got a little bio on the MSK website, and he says, I am a neuro-oncologist who cares for patients with brain tumors and neurologic complications of cancer. I work with a multidisciplinary team of physicians, which is really, really important, nurses, very, very important, and administrative staff, very important, to provide patients and their families with the best possible care. What do I do at MSK? I am a neuro-oncologist, and this is a doctor with special training in cancers that affect the brain, spinal cord, peripheral nerves, and muscles. And this includes brain tumors and central nervous system tumors. I am an early drug development specialist, which is a scientist who tests new drugs to treat cancer. And thank you. I have special training in research studies, also known as clinical trials. We are so delighted to have you today, Dr. Grommes. I also was reading, your patients love you.
That's
Yeah,
always good to hear, isn't it?
you've had I know you work with a lot of patients, but you've had some of the most recent comments related to you from patients. I just wanted to read one because I just thought it was really awesome. Dr. Grommes and his nurse Haley have our utmost gratitude. Dr. Grommes has been treating me for years, and I have total confidence in him. He is a remarkable physician and a genuine and caring person. I mean, what more do you want from your healthcare provider, right?
Yeah. Well, I try my best. Well, it's
Yeah.
actually it's the team around me that makes me special. And that is again, I think we have a special place here in New York at MSK, and so I'm just the one of the pieces of the puzzles, I think.
Well, you are fantastic. So
Oh,
thank you.
thank you.
I will, at this moment in time, turn it over to you to further introduce yourself or say anything that you would like before we start our interview.
Yeah. Well, first, thank you for inviting me and having me here. It's a pleasure and a privilege to, be here and talk a little bit about PCNSL, primary central nervous system lymphomas. It's a fairly rare disease, but if you train here at Memorial Sloan Kettering, you think it's the most common brain tumor ever. We see fairly a large group of patients. And yeah, a few words about me. I'm a neurologist, neuro-oncologist. I started my journey at MSK in 2009 and have been here since about 16 years and focused my preclinical and clinical research in PCNSL. And have developed and grown a clinical trial portfolio for those patients, in particular when the tumor comes back or is not responding to the initial treatment.
And we would refer to that as recurrent.
Yep,
Yeah.
recurrent or refractory PCNSL.
Thank you. Thank you. I also want to thank Curis Therapeutics for bringing us together, for investing in the disease of PCNSL and into this research, and for helping you and I and the End Brain Cancer Initiative with this educational video for patients and the PCNSL community and the distribution, which will be global, helping us with this project. So thank you, Curis Therapeutics.
Thank you.
You can't do these kinds of things without you. What is the basic definition of PCNSL?
So PCNSL, or primary CNS lymphoma, it's a mouthful, but I usually like to just say primary CNS lymphoma, is actually a lymphoma that is limited to the brain, the spine, the spinal fluid, or the eye, so the central nervous system, CNS. It is interesting because there is no real lymph structure like we know it from the rest of the body with a lymph node and other lymph organs that we can identify in the brain. So that was always fascinating to me. And it is actually a brain tumor, a malignant brain tumor that we can treat, and we can see some responses to therapy. So that's why I also got very interested, because we can be fairly aggressive in the treatment. It's also rewarding because we can reach very, very good outcomes with some of our patients.
What are possible causes and risk factors of this disease?
So there are two kind of groups of patients. So we have the immune suppressed patients, like organ donation recipients, or AIDS patients, or patients on immune suppression. They can develop a primary CNS lymphoma, but the majority of patients are elderly patients, immune competent, and these patients develop primary CNS lymphoma. And we have a population that is getting older and older. And so we see a slight increase in the incidence of these tumors. And if I would be loving to be a little bit more specific about what's causing them, we haven't really figured this out in all the detail. So if there is exposure or other things, we can't really say for sure.
Not yet.
Correct. Not yet.
Not yet. We will be. I'm sure that we will be able to. My organization and I have worked with some PCNSL patients that are actually quite young.
Yep.
So you don't see that as much, but you do see it, right?
Yeah. Yes.
Right. Okay.
It is usually the general patient population is 60 and older, but you see primary CNS lymphoma patients that are younger. In general, the younger patients have a much better outcome because also they can tolerate more therapy, more intense therapy. And so yes, but we see this disease more in the 5th to 6th decade of life.
Absolutely. And I think it's something important for people to understand is that PCNSL I describe it as ultra rare. Is that correct?
Yeah, PCNSL is a rarer disease, so it's about 0.4 per 100,000 per year, so 30 people here in the New York area that have primary CNS lymphoma or develop a primary CNS lymphoma per year, and about 1,500 in the US. So that is not a very common disease compared to more common disease like glioblastoma or lymphoma outside the brain. So that is something that we see more frequently than what I see. Yeah. in my work.
So lymphoma out of the brain. We're still talking central nervous system, right?
No. I meant,
No. Oh, okay.
lymphoma, like diffuse large B-cell lymphomas of the body outside the central nervous system. Yeah.
I see. So if we were to say with this particular disease that in the United States, there's approximately 1,500 new cases a year. Do you know what the stats are as far as like how many people in the US are living with PCNSL? You
Well,
know,
that actually depends where you receive your treatment.
oh,
Because if you go to a specialized center, and there are many around, not just us, then there's more access to clinical trial, more advanced therapies, potentially with targeted agents. There's also more expertise in the management of side effects, in particular management of chemotherapy-related side effects. And the biggest culprit here is methotrexate. These patients all get methotrexate, and it can be very toxic to the kidneys. And if you have experience managing these complications, you have a better outcome. So, but we always state that about 80% of patients have a response. The big question is how long that response will maintain. But the rule of thumb is about 60% of patients are disease-free after 2 years of chemotherapy in a specialized center. The numbers are a little less promising when you look at the entire US population.
okay. I mean, honestly, that's promising, right?
Yep.
When you say 80% response and then we get to 60%, I mean, we both work in an area and a space where, we don't see that a lot with other brain cancer, right? So I feel like that's very good information and very good outcomes. We want it to be more always. So that's great. And you just brought up a good point. You are treating patients, working at and doing your research at a specialty place for PCNSL patients. All right.
Yeah.
And so, yes, there is more expertise there. And yes, there are more clinical trials and more advanced diagnostics. All of those things make such a big difference in that ability to not only treat a patient and have, we hope, positive outcomes, but I feel like it also provides the ability for the patient, caregiver, care partner, family to have more hope with this disease. And I kind of think about that, and I always think about if possible, why would anyone not choose to be treated at a center that's known for whatever disease you have, known for its expertise. So that's one of the jobs that we do at the In Brain Cancer Initiative is we help people understand their options. And then we literally will help make those introductions for them to the specialists wherever they're at in the country based on their information, right? Based
Yeah.
on their genomics or their biomarkers or all of those things. And there's a lot going on in that brain tumor space. It's pretty inspiring, really. But you got to sometimes seek out additional treatment options. Lots of times people have never heard of PCNSL. What can you tell us about common symptoms of this disease?
Common symptoms of PCNSL depend on where the tumor is located in the brain. They usually develop over weeks to months, so fairly fast, but also not too acute. And usually affect the deeper structures of the brain. So patients changing in their behaviors, they have memory issues, sometimes even weakness, gait difficulties, speech problems, but it's usually cognitive changes. There is sometimes a little bit of a delay because these patients are elderly, and then everyone approaches them and says, well, you're getting older, that's why you have symptoms. And there can be then a little bit of a delay. before they get their imaging done. One part of lymphomas or PCNSL is also that patients can have ocular involvement first. And so the symptoms are then blurry vision or just other visual changes. And the original assessment by the eye doctors is more like, well, you have an inflammation, you get some eye drops, and then it just drags on before there is then an ultimate diagnosis, or people then develop brain involvement and have neurologic symptoms. So that can also happen. Sometimes also patients just don't know that they have the opportunity to get a second opinion. Especially nowadays, it's so much more. Yeah, the world is getting smaller. You can get telemedicine visits, and so you don't really need to go to a big city if you can't afford to go to a big city, or if you're a little bit anxious of traveling to a big city, you can always try and do telemedicine visits and get a second opinion. I don't think that a second opinion hurts. The more opinion you get, sometimes the better. It, number one, confirms what you hear about your disease, what you hear about your treatment. You can then pick and choose what you like, who you like, and then sometimes the bigger hurdle is actually the insurance and insurance coverage for particular networks and hospitals. But that also can be overcome if you enroll into a clinical trial that is only offered in a particular center. So there are ways of getting more information and education from different physicians about your disease.
Absolutely. We want everyone to get a second opinion. And, a second opinion can also be like a third opinion, right? But at the very, very least, I almost don't care what you're diagnosed with, frankly. Get a second opinion from someone who is considered a specialist in whatever disease you've been diagnosed with. Question for you, Dr. Grommes, is do you do telehealth second opinions?
Yeah, I do telehealth second opinion. The problem sometimes is that you have to hold a license in the state where the patient is located.
Yes.
And so that sometimes limits the abilities of telemedicine visits that we can do. But many states also now offer just telemedicine licenses. So the outreach is getting further. Yeah, most of the disease specialists do have telemedicine visit opportunities.
Okay. So you're in New York. I want to be really specific, if I could, on the telemedicine because it is so important. I don't know for you, and I do understand the licensing. I understand all of that, right? For you, are you saying that you can provide a telemedicine consult or second opinion for New York residents only?
Oh, I have multiple licenses. So
Oh,
because of my
you,
background and my training, I have a few more states in my pocket.
are you able to share those states?
Sure. Yeah, well, I have no problems with sharing these states, but it's Ohio, Pennsylvania, New Jersey, New York, and Virginia, actually.
Thank you so much because that's incredibly helpful information.
Mm-hmm.
So thank you for having licenses in those states, so that you can offer your expertise to others who live in those states. Thank you. When we put this video together for patient disease education, awareness, and outreach purposes, are we able to share your information? So when people see it, if they would like to have a consult with you or a second opinion, they know how to reach you?
Yeah, that's fine. We also do have record review options in case there is no telemedicine option available. But again, there are some states where you don't need to have a license to still do telemedicine. But yeah, I would be happy to do that.
Can you explain for our audience what the record options means?
Yeah, so the patient sends in their records, their medical records, their images, the path reports, the lab results. We review them and then get back to the patient with an assessment, with a recommendation. Sometimes patients also like to ask some questions with that, and we answer those questions. And usually it's like a written report that they get back, and sometimes we also reach out with the phone, discuss a little bit what we recommend. And do like this kind of record review as a service, obviously, for patients.
That is fantastic. Thank you. I know, I understand it's time consuming, but that is such a benefit to the general public. And particularly, we're talking about this particular patient population. But thank you for doing that. I also will say, if it's okay, our patient navigator with the In Brain Cancer Initiative is very helpful in helping people gather the necessary reports and helping them write their questions out so that they can provide everything in one beautiful package to you for a second opinion. So at the end of this video interview, we'll pop up our patient navigator's name and her contact information, and she's free to utilize her expertise to help all patients, all families, all caregivers, all care partners, all healthcare providers as well. So it's amazing. Okay. I'm so excited that we get to talk. So what happens, pretend if you would, maybe, that something's going on with me. I don't know what. I walk in and I get a PCNSL diagnosis. What happens next?
Yeah. So generally, these PCNSL diagnoses are established through a biopsy, sometimes a resection, so neurosurgical procedure after a lesion was found on the MRI scan. In some cases, also patients can get a diagnosis through a spinal tap or lumbar puncture when we collect the fluid that surrounds the brain and spine and we find malignant lymphoma cells. So that establishes a diagnosis, and then, it's all about treatment, and it's chemotherapy only. We try to avoid radiation because PCNSL is a very chemosensitive disease, and the main treatment, well, there is no gold standard that is defined, but we all in the field agree to use methotrexate. It's a methotrexate-based chemotherapy because we combine methotrexate with other agents, and the partners range from where you're trained, from the latest published data, to what you're comfortable using, and it's usually at least 3 drug combinations, unless you have some comorbidities or you're a frail person. Chemotherapy should not be limited to those with a good performance status, like we do in other brain tumors, because again, this is a very chemosensitive disease, and we have seen multiple times that patients that are really sick, if they respond immediately, well, not immediately, but tend to get better very quickly.
Is there a difference between a lesion on your brain and a brain tumor?
Depending, yeah. Some of the lesions in the brain are not necessarily malignant. There is a particular characteristics of these brain lesions that make them suspicious for a malignant process. And so then the question is it a malignant glioma, or it's a malignant lymphoma, or is it a benign lesion like a meningioma? Depending on where the lesion is in the brain or how it looks on the MRI scan, we kind of have an idea what it might be. But at the end of the day, there should be a biopsy to prove what kind of underlying disease it is, because there's wide differences in how we treat them.
Absolutely. That biopsy, not only is it helpful for pathology, right? But there's also some incredible information within that lesion or tumor tissue that is really important to identify to help treat, right?
Yeah. Also, maybe if I may say, the extent of surgery also depends a little bit on what we think the tumor is. Again, in lymphomas, we like to limit the surgical interventions because we can shrink the tumor with chemotherapy. In high-grade gliomas or other gliomas, we like to take as much out as possible. So there's a little bit of a difference. So that's also why when there is a neurosurgical procedure for a patient with a suspected malignant brain tumor, that there is a biopsy or a piece is taken, and within the surgical procedure, the pathologist looks at that and then guides if there is more surgery indicated or not, depending on the pathology. Again, we like to not that I'm a surgeon, but our neurosurgeons like to not bisect lymphomas because you resect also normal brain, and so the risk in PCNSL for permanent brain damage is basically, not from not the entire surgery, but you can resect a brain that can lead to deficits that don't go away, and we can potentially avoid that by just taking a biopsy and treating the tumor with chemotherapy, which is different than what you usually experience with gliomas.
Right. Absolutely. You used a word, and I'm not sure all of our audience will know the meaning of it. So if you can explain it, that would be amazing. Comorbidity.
Yeah. So comorbidity means what other diseases or what other medication or what other factors affecting the patient's functional status. So the more diseases a patient has, like diabetes, hypertension, high cholesterol, prior heart attacks, coronary artery disease, the harder it gets to treat those patients, particularly because our chemotherapy with methotrexate requires a lot of IV hydration. And so patients with prior cardiac problems have sometimes difficulties managing through the therapy. So that's what I meant with comorbidities.
Thank you so very much. Okay, so you mentioned where you practice, MSK, is a center with PCNSL expertise. How do other people, find these centers that have expertise in PCNSL?
Yeah, well, by talking to their physician and also, with organization like yours to kind of get an idea where centers are. Sometimes also what we do is to work with the local oncologist to kind of reassure the patient that they're on the right track with the right treatment, assist with managing of adverse events that come up during chemotherapy. But nowadays also the world, as I said, is getting smaller. So there's a lot of information also on the internet. That's kind of the avenues how patients can get a little bit more information about their disease.
Fantastic. And I know that part of our patient navigation services will help others also identify and make a direct connection to the specialist within that center that for PCNSL expertise. So we just want our audience to know that as well. Okay, so we're going to wrap up our first session, which was what is PCNSL? We're going to head into our session number 2, which is more in-depth treatment options. You talked about something that was very interesting, that within PCNSL disease, I think I heard you say, there really is not a standard of care. So my question might sound a little strange, but here it is. Standard regimens. I think we are talking about standard treatment protocols and their side effects.
Well, standard of care is defined as everyone uses it because everyone we have data that shows that is the best treatment at this moment. Well, what we don't have is a lot of phase 3 comparison trials in PCNSL. What we do all have is phase 2s, larger phase 2s, a few phase 3s. And ultimately, what we can argue, or what we all in the field agree, is that it needs to be chemotherapy, and the chemotherapy should include methotrexate. And so that is the first step. That's what we like to do, and we combine it with other agents. Now, methotrexate is also, unfortunately, the most potentially side effect ridden agent because it can cause renal failure. And so you have to be very careful by giving it. The patient needs to be generally admitted, gets a lot of hydration, and we have to make sure that the methotrexate is cleared out of each patient's body before they can go home. We treat patients every 2 to 3 weeks with methotrexate, depending on the regimen that you use, to avoid also effects on the bone marrow from the methotrexate and other agents. And that is, I think, what we all, as a minimum, agree on. And then the methotrexate has come out with other agents, again, depending on your experience and the patient, as well as your training.
So how long is a typical treatment last?
Yeah, so we like to use 8 doses of methotrexate every 2 weeks. So 16 weeks generally is the phase with the methotrexate, which then is generally followed by something we call consolidation, meaning we like to switch chemotherapies to make sure that there's no early recurrence by giving some additional treatment.
And then if you say you admit the patient for a treatment, right?
Yeah, we do.
And then
Yeah.
you make sure that it is cleared from their body before they get to go home. Is there a kind of a typical time period for receiving like one treatment? Like does it last like 4 hours? I don't know.
Oh, I see.
And
No, no. So, so you come to the hospital, you get your hydration, you get your chemotherapy, which is generally methotrexate is infused within like 2 hours, and then continued hydration. And then every day we check the level of methotrexate, and if it's under a particular threshold, patients can go home. Again, we're very concerned about the effects of methotrexate on the kidneys, also on the bone marrow, but mainly the kidneys. There are some institutions that do give methotrexate now in the outpatient setting in a very highly selected patient population because you have to really make sure that they hydrate well and that there's close follow-up. But this is a disease in the elderly patient population, and there might not be a lot of functionality. You need a lot of family support if you do this in the outpatient setting. We also have, investigating some new approaches on how to deliver methotrexate in the outpatient setting. In every patient, there's obviously more going on to make this better and easier for our patients because who wants to be admitted every 2 weeks for 3 to 5 days? It's also taxing for some of our patients, and so yeah, but that's generally.
okay, so that admittance is from 3 to 5 days.
Yep.
Ah, I did not understand that. That's good to know.
Yeah.
That's good to know. And so you did mention that healthcare providers pay very special attention to the levels of this drug in their kidneys or anything else. I assume there's quite a bit of blood work done. And did you say you check it it's checked every day that they're within the hospital?
Yep. And if they're in the hospital and the level is too high, then we have to be a little bit more intense. We intensify our ways of protecting the body from methotrexate and getting the methotrexate out. I have seen it both ways. On the one hand, there are families that say the whole every 2 week being admitted is taxing, and we have seen patients that are part of our trials to use it as an outpatient. Said, that back and forth is not that easy. I want to be admitted so I can focus on being in a hospital, clearing the methotrexate, and can go home. So it really is not a straightforward path, and I think it depends on the preference of the patient, the family situation, but the location. Manhattan doesn't have a lot of parking spots, so getting back and forth here is a little bit more difficult. Is really the more intense part of this treatment.
Thank you. Is there anything else a patient could expect with treatment?
Well, yeah, each of the drugs that we combine with methotrexate has its own side effect profile. In general, what we try to avoid is count drops, the white count drop, the platelet drops, or the red count drops. So we give supporting medication. Some of the medications, for example, vincristine that we sometimes give with methotrexate can cause neuropathies, so we have to look out for that. Nausea can happen with just doses for that, liver enzyme elevation. So me personally, I like to start with all agents and peel off agents depending on the side effect profile rather than start timid and add things. Especially in a disease that is chemosensitive. This is not like a glioma. You want to be upfront, you want to be aggressive, and you want to give the patient as much chemotherapy as possible. And if you have to peel off, that is, I think, the better approach than adding on, because you might never get to it because of side effects up front. But yeah, I think there are treatment differences depending on where you get your treatment, but it's generally all of the time based on methotrexate. It gets a little bit more challenging if you have difficulties with your with your kidney. and you have chronic kidney failure, or you have a kidney transplant already, to give patients methotrexate, then it gets a little bit more tricky. And I would then recommend really to go to one of those special centers, because they have a little bit more experience with giving it to patients with maybe only one kidney or after kidney transplant. And that is actually a very common scenario that I see patients that have developed kidney problems with one or two treatments of methotrexate, and then what to do now. And so that's actually something that happens very commonly.
Okay, thank you for that information. The next question is about outcomes and rates of, I use the word remission and you use the word refractory, right? So what would you say about that?
The question about outcomes is always how you define outcomes. So first, there's a response. That means with the means of detecting the tumor, do we see it shrinking? So you can have a partial response, a complete response, stable disease, or none. None of that, and that is progression. And so the next step then is, if you have no response to therapy, then that is called refractory. What you also can see is there's an initial response, and then it bounces back immediately, and that is also refractory. That is actually methotrexate refractory disease, which is extremely difficult to then treat. And so, but in general, well, let me say, it's about 15 to 20% of patients that are refractory to methotrexate. And that is, again, difficult to treat population, but about 80% of patients respond to methotrexate and then receive a consolidation if they can, if they're able to tolerate that. Then we're saying, okay, the imaging doesn't show anything, so we are in remission. Now, in other cancers, in other lymphomas, if there's a particular time frame that is passed and you're in remission, then you're cured. More primary CNS lymphoma can recur after 5, 10, even 15 years. So even though I would love to say you're cured, I can't really say that because it's a possibility of late recurrences. So I usually like to mention to patients that they're in remission. But so the remission rates at 2 years usually are around 60%, a little bit better or worse, depending on your age group and your comorbidities again. That is, again, mostly in specialized centers. Outside of specialized centers, it might be a little less, but again, that really depends.
Thank you. Thank you. So if I'm a patient or I'm a care partner and my loved one is going through treatment, what would I look for that would be harmful, right? Like what am I looking for that would make me go, wow, we need to go to the ER. We certainly need to let our physician know what is happening. What types of things would we be looking for?
Yeah, clinically, not that much. Actually, we would be very concerned if a patient doesn't get better neurologically, because that means, the chemotherapy is not working and that's a refractory patient. Or if patient get better and then worse again. But that's another thing. The neurologic exam or the neurologic presentation is really helpful in our patients. Now, we do regular blood counts on these patients in the hospital, outside the hospital. So we know when their platelets, for example, are low. So we are not really seeing surprising admissions because there's a hemorrhage in their brain because of a low platelet count, because we monitor these patients very closely. Yeah, I usually say to my patients, if there's any change in their neurologic presentation, even if they're concerned about small changes, they can just always get in touch with the team and me, and we determine very quickly what happens. The good thing about these patients is every 2 weeks, they're also in the hospital. So we really have a close understanding of their clinical journey and their counts. And so it's rarely that these patients slip through and develop a symptom that we don't see coming.
It's quite honestly quite wonderful that these patients are, I'm using the word monitored so closely and often. You don't always see that in other diseases and other cancers either. And so that is fantastic.
Well, we do treat also these patients with a lot of chemotherapy. So we do have to monitor them closely because they can develop thrombocytopenias, also low counts of their platelets, low counts of their white count, and that sets them up for potential bleeding risks or potentially infections when the white count is low. And that is obviously different than what we do with gliomas, where we do radiation and temozolomide chemotherapy, and it's not as intense. And unfortunately, I also, if I share, had once a family where one person had a glioblastoma and the other one had a lymphoma in different times, and the glioblastoma patients unfortunately noticed, why am I not treated as intense than my family member that had a primary CNS lymphoma? And that is just because the intensive chemotherapy doesn't work as well in glioblastomas, so that's why we don't actually do that. And so that's sometimes a very stark difference, and that's why also we don't do the controls or the supervising and the lab values in glioma patients that frequently, even though we do look at them every week too.
Yeah, thank you so much for explaining that. That's very helpful information. We'll wrap that section up, which was treatment options. The third section is relapse and progression. We have time. I want you to know we're not rushed for time, so you can certainly explain this as much as you would like to. What happens if the disease comes back?
That is a very good question. When the disease comes back, we have multiple options depending on when the disease comes back in the journey of the patient. So if the disease comes back within a year of the original chemotherapy with methotrexate, that is in a different situation than if the disease comes back 5, 10, 20 years after original methotrexate. So you can always use methotrexate again, the longer the time frame between the last methotrexate and the recurrence. So that is something we have done a lot. And now we have more options that are targeted agents, where we use something called a Bruton tyrosine kinase inhibitor, which is an oral drug that you can take, or immune modulating medications like the IMiDs, like lenalidomide or pomalidomide. That's also a drug that you can take orally. You can use chemotherapy with agents like temozolomide or pemetrexed. So these are all options that are outlined in the NCCN guideline. Now, again, there is no gold standard because we do have only limited clinical trial experience and no randomized trials that defines the right treatment options at this time. I think that we will see in the future that that will change because there's an explosion of treatment options for non-CNS lymphoma, and they trickle into the CNS space. And so there's a lot of interest, a lot of potential avenues to go. And I think within the next 5 to 10 years, we see more treatment options that are also based on more data, clinical trial data.
So that's fantastic. I mean, I'm hearing what you're saying is that there's more interest in research in this area for these patients, right, who are or will be in the future diagnosed with PCNSL. That's pretty amazing, fantastic, and wonderful because this is an ultra rare disease. So it always warms my heart when I see industry and researchers, healthcare providers, doctors such as yourself, placing an amazing, wonderful focus and resources into this research into rare disease. Thank you. Again, thank you. You mentioned something, and I don't know if our audience will understands this, so I'm wondering if you can explain targeted therapies a little more.
Yeah. The concept of targeted therapies is to attack a vulnerability of a cancer, the Achilles tendon of the cancer. In primary CNS lymphoma, we have learned that there is a pathway, the B cell receptor signaling pathway. So every B cell, which is usually the malignant cell, has a purpose when it's not malignant, and that is to bind to something and activate that pathway. And it seems that that pathway is usually upregulated in lymphomas of the brain. And by targeting specific proteins that are part of that signaling axis in these cells, the cells die. And so this is a concept in oncology that has been used in other cancers, in lung cancers, and also, lymphomas outside the brain by using these very specific inhibitors to take out proteins that are important in these signaling axis, and then the cells die. But that's also their Achilles tendon is if you only have one cell that is able to avoid dying from this medication, these tumors grow back. And that is the downfall of these targeted agents at the moment, is that there's a high response rate, but the time that response maintains is short. So that's why I think, again, in the future, what we want to see is combinations of these agents with conventional chemotherapy or different agents. So you target multiple Achilles tendons of a cell to then, kill them all. That will be the idea.
That is fantastic. You mentioned also, I think you mentioned phase 1 clinical trials, phase 2 clinical trials, and phase 3 clinical trials. Would you please explain each one of those?
Yeah, that's a very good, yes, I should explain the phases of the trials. When you have a new drug that has been developed in the laboratory, you have no experience with that in human beings. You have an idea about the toxicity, sometimes from preclinical studies, so you start at phase 1. The phase 1 is all about finding out what is the dose that I can safely deliver to a patient. Not about, does it work? Does it kill cancer cells? None of that. It's like you start with a low dose of the drug, you go up until you hit toxicities, and then you stop. That is the phase 1. Now, why would I, as a patient, go into a phase 1? Because it's all about toxicity. Sometimes these phase 1 trials have very exciting drugs that are actually very effective. So you have first dibs into that. This is maybe something I would not immediately jump on if I'm newly diagnosed and have an established treatment regimen. That is the phase 1. Well, phase 2 now takes that drug at the dose that we know is safe because we established that in the phase 2, in the phase 1. And now give it to patients and see, does it actually make an impact on benefits and clinical benefits, outcomes, responses, and these things. And we usually compare that with historic controls. And if it's promising, we take it to a phase 3, where we combine standard of care versus the new drug, or standard of care plus the new drug. And so that will be a phase 3, that if the phase 3 shows that the new drug is much better than your standard of care, then that will become the new standard of care.
Fantastic. Thank you. Thank you for explaining that. I know a lot of people don't understand clinical trials.
Yep.
And I know that there is a lot of people are fearful of clinical trials. And I feel like it's only because they don't understand them. There's not enough education about clinical trials.
Yeah.
And your explanation of phase 1, 2, and 3 was fantastic. So thank you so much.
You're welcome. If I may say one more thing about the trials, if you
Please.
allow. There's every patient that enrolls in a clinical trial does that voluntarily. So there should never be pressure to enroll in the clinical trial. There's an informed consent form that is written in a way that every patient should understand what this all entails. And I always say that to my patient. It's not buying a house. You can always step away from the trial if you don't like the trial, if you think it's too much traveling. And it should and will not affect your treatment afterwards. Another thought is, in a phase 3, for example, you have a control arm or a placebo arm, depending on what it is. And then also the question is, why should I enroll into something like that? There is a benefit of being enrolled in the clinical trial, because even though I just talked about this, how closely we monitor our patients, there's an even more scrutiny on the surveillance of these patients to make sure they're safe. So I think that is also of benefit sometimes for our patients. I think the message here is it's up to the patient to enroll, and the patient can always step away if they want to.
I completely agree. The other thing too, and you mentioned this, the informed consent form, which is something that has to be signed before anyone can enter into a clinical trial. It is giving the patient's approval of, yes, I want to enroll into this clinical trial. And like you said, you don't have to stay in the clinical trial. Researchers and doctors and physicians would hope that you would, but if
Right.
there is a real reason for you to step away from the clinical trial, you have that ability 100%.
Yeah.
One of the things, speaking of informed consent forms, that I personally would like to see as a patient advocate and a person who works with many patients all the time, I would like to see those forms to be patient friendly in the language, because they're not. And there should be that big long legal form that people are like afraid to look at and sign, even though it's fine. And then there should be this like one pager that actually explains it in patient friendly language. I mean, that would be beautiful for the
Well,
patient.
yeah. So these informed consent forms should be written in English of an eighth grader.
They
So
should be.
to understand it, yes. They are sometimes very thick, 30 pages and more, I know. But I agree with you. There is actually, at least at our institution, a page or two where it's like just a general overview of why this is done. And then in more granularity, the details of all these things. I also think that every patient should not feel rushed. They should have enough time to read the consent form and then to ask questions. And so there's no penalty in taking your time reviewing these things and asking questions about the trial.
That's great advice. Thank you. Before we move into a discussion that's even deeper related to clinical trials, I'm wondering, our audience may not be aware of what the NCCN guidelines are, what they are, one, and two, of course, what they are for PCNSL. Would you take a moment to explain those?
Yeah, so these guidelines are for rare diseases where we don't have larger clinical trials to guide us. And so there are disease expert panels that come together that discuss, data that has been published or that discuss experiences with drugs in its patient population, and then they vote. They put it on the guidelines or not. And so it gives physicians in the US, well, also worldwide, but mainly in the US, the ability to use agents that are not FDA approved for this disease, but guideline recommended, to then go to the insurance companies and say, we really want to use this drug. Again, it's not one person, it's a panel. It's, again, a very diverse panel from different walks of the way in the United States with disease experts. So not just one region versus another, that comes together on a yearly basis to define what is a good guideline in treating these patients. And there are some treatments that are in the guidelines, but they're not highly recommended versus others that are highly recommended. And there is an evidence to it. There is the evidence that there is clinical trial data based on randomization. Then the next step is clinical trial data, and gets less and less obvious. That the data gets less and less concrete. And so, but it gives us as treating physicians a little bit more leeway with particular insurance companies.
Oh, that's interesting. Okay, so particularly with insurance companies. So, question, if the drug is within, or the treatment is within the NCCN guidelines, would we expect insurance companies to cover that treatment option, that drug, that diagnostic, that whatever?
Again, depending on the level, yes, there are some, again, the higher the recommendation level, the more likely it is that it's covered. So, but yes, that's where the NCCN guideline comes in to help us
Okay,
with that argument. Yeah.
that is fantastic. Thank you.
Yeah.
One thing you mentioned before, and I'm wondering if you can explain it just a little more. Within clinical trials, you talked about the treatment, the drug, the whatever it is within the clinical trial that's being tested, researched, but you also talked about the word placebo. Can you explain?
Yeah. Well, so particularly in phase 3 trials, the patient as well as the doctor don't know what treatment is given, and that's the whole purpose, that you don't bias patients and responses. And that's where placebo comes in. There are some trials that have placebo as a treatment. So it's either observation versus something, but the patient on observation gets a placebo. That's not usually the trials that we have in neuro-oncology. In neuro-oncology, it's the standard of care plus placebo, plus the standard of care and the trial agent. The purpose of that is to reduce bias by us and the patient knowing what they're taking. It's not really very common that we see that in neuro-oncology, to be honest. But that is what the placebo is there for.
And then, something else maybe would be interesting for the audience that's going to be reviewing this patient disease educational video. Within clinical trials, can you please explain for those clinical trials that have that crossover protocol built in, what is that?
Oh, it's getting a little more complicated, isn't it? But yes, what is the crossover? So, for example, if you are on a study that has a placebo or that has a different treatment arm without the agent, you can say at the time that you have a progression or the treatment is no longer working for you, we unblind you, we find out what you have, and if you have not had the drug, you can roll into or you cross over into the drug group. Now, this is obviously helpful when you look at, it's helpful for the patient because you know that you sign up for a trial and you will get the drug earlier or later. Sometimes it can be a little bit difficult to interpret these results because, when it comes not to response, but to the overall survival, you might just not be clear what is working and how and what is contributing. But that is what the crossover is. It just allows patients that have been randomized to the non-treatment is the wrong word, but the arm without the novel agent to then receive it later. Yeah.
Wonderful. One more thing, definition for clinical trials, randomized.
Yeah, so randomized is flip of a coin, isn't it? So there is generally nowadays a machine that, or computer, tells us in which arm the patient goes into. And that is randomization. And so it's not me that determine, again, being biased, this patient gets this treatment or that treatment. And so that is randomization. And sometimes the randomization is just like that, or we kind of put an emphasis on making sure that the randomization follows some patterns, that we have not just old people in one arm and young people in the other, or very healthy people on one side versus very unhealthy in the other. So that depends a little bit on how the trial defines the randomization process. But randomization is literally a flip of the coin, which arm you get into.
Thank you. Are you able right now, and right now is September 26, 2025. Are you able to give a brief on the current clinical trials that are recruiting? They're open, they're recruiting for patients right now. And we can just talk in the US if you want. Are you able to talk a little bit about those?
Yeah. So in lymphomas, primary CNS lymphomas, there are basically two groups of patients. And that is, I think, true for all brain tumors. There's the first line trials and there is the recurrent refractory lines. And so for first line, it's all about adding stuff to methotrexate. That's what's going on at the moment to see if novel agents or novel treatment options make a difference. Also, there are some trials where we look at different consolidation regimens to see if they make a difference. In the recurrent setting, it's all about targeted agents, BTK inhibitors, gluten tyrosine kinase inhibitors, targeted agents combined, targeted agents with chemotherapy. There's some CAR T cells. We haven't talked about CAR T cells yet, but that's a treatment that has been established in lymphomas outside the brain to take the patient's own T cells out of the body, modify them to recognize the cancer cells and put them back in. So that's the idea in now in CNS lymphomas too. There's also bispecific antibodies that have been established outside the brain in lymphomas that will have a role in trials for the CNS lymphoma patients, and obviously agents that are antibody drug conjugates. Long word to say we attach something like a chemotherapy or a radiation source to an antibody that then finds the cancer cell, binds to the cancer cell, and treats the cancer cell right there locally. See, these are new kind of options for trials. And so I think the general direction goes into very targeted specific treatment and how to engage the immune system. I think that's the bigger direction this all heads. Yeah.
Okay, thank you very much. Very much. Okay, so that wraps up section 3, which was relapse and progressions. And now we are going to move into section 4, which is interesting. It's challenges and unmet needs. And so when we say unmet needs, from a patient advocate perspective, I'm thinking about what patients have said or expressed and their care partners about what is unmet, what their needs are that are unmet. But it's interesting to talk to you because I would imagine specialists such as yourself in this particular disease state have distinct unmet needs. Is that something you would like to address?
Oh yeah, I want to address unmet needs because, we talk now for a long time that this is a treatable disease. We have remissions, we even potentially have cures. And yet, when we looked at a larger US database for primary CNS lymphomas and how survival, not just response, survival has changed. It changed in the 1970s from a median overall survival of 12 months to now a median overall survival of 24 months in the US. And that is not what I just talked about. And so there is obviously an unmet need. The unmet need is particular in those patients that are older than 70. And so these patients might not be able to tolerate a lot of methotrexate chemotherapy, or they run into difficulties with methotrexate chemotherapy, or they decide, I don't want to be admitted every 2 weeks in the hospital, so I don't want any treatment. And so that is, for me at least, the biggest unmet need. For the patient, I think the unmet need is to define what kind of treatment do I choose. And we haven't even talked about radiation at all, but it is possible to give radiation in these patients. And what treatment do I want that, if I am literally cured, gives me the best cognitive outcome in the long term? And so that is an unmet need. But again, the problem is, how can we make upfront treatment better so we don't run into recurrences? And that is another third unmet need, is that we don't have a biomarker that can define something we call minimal residual disease that we don't see on the MRI scan or spinal fluid collections that defines a patient at risk for an early recurrence. And we don't have that.
We don't have that yet, maybe.
That's right.
Yeah. Okay. Because, boy, that would be beautiful.
Yep. Also, you could spin it further. If you have a biomarker that predicts that you're not at high risk of a recurrence in the first place, why doing all these aggressive treatments? So you can peel off chemotherapy even.
Okay. That's interesting. That's a very interesting philosophy, but also just a very interesting practice. Because I noted that earlier when you said, I interpreted it as you like to start aggressive. You like to give the patient, if possible, everything in your toolbox.
Yeah.
Right? To get rid of this disease. And then if you need to, you use the word peel back. Is that a your word, or is that like a doctor term?
No, I think that's my word. Yes. Yeah.
Well, I like it. And it makes sense. You just peel back, different treatments if the patient, is not responding well. That's great.
Yeah.
Wow. Wow.
Yeah,
Okay,
but
so
it would be nice to have something that I could categorize patients up front and say, you are at really high risk to have a tumor growth within the next 6 months. And we have a patient, you have a low risk of having a tumor growth within the next 5 years. Then you can approach this and say, well, why don't we treat these patients potentially differently? I think that's really missing at the moment.
it is missing. I mean, I know, there's a lot of research going on in this area, like even liquid biopsies, right? Like, and so I know, I suspect from a healthcare provider and researcher perspective, that would be amazing information to have up front. But I also think from a patient perspective, care partner perspective, family perspective, having that information up front, I think it would be beneficial for that patient to have that information because I do think I think more information the better to
Yeah.
make informed decisions. I mean, I feel like if I were this is me, so I'm just sharing. If I, having been through a illness with my late husband, if and now there are tests to help determine this, but if we had known some of what can be detected now as far as pretty much how fast it's going to come back or not, those would have been very helpful. That would have been helpful information to have up front for so many reasons, right? We might have chosen to do something earlier than later. We certainly might have chosen to be more aggressive in treatment. We might have considered even like a clinical trial sooner than later. That kind of information is just, or we might have taken a trip or something
Yeah.
also. I mean, who knows? But the more information, the better to help not only the physician and the researcher and the healthcare provider and the principal investigator of the clinical trial, but it means so much to that patient and their family. I think we should really move in that direction.
Yeah. Well, if we
You know,
can, see, that's the thing. But that's also going back to the second opinion. You should, there's a fine balance. If you get one second opinion or two second opinions, but sometimes what I also unfortunately see, not so much in lymphomas, but more in glioblastomas and gliomas, is that there is a newly diagnosed patient. It's a highly aggressive tumor, and there's one after another of second opinions, and time ticks and ticks and ticks, and no one does a treatment. And so
oh, got you.
that is something that, I encourage second opinions, but there has to be a point where you say, okay, now it's enough. Let's move on to treatment.
Right,
Yeah, because
right.
I think I see the second opinion more like an an opportunity for the patient to learn more about the disease and to hear, are the recommendations about the same? Are they different?
Mhm.
There are some people, I have strong opinions sometimes too, but I think in general, 80% of the information everyone gets is about the same in all the encounters. And then the last 20% is all about how I treat and what I do and my trial portfolio versus another trial portfolio. That's usually,
Yes,
yeah,
exactly. It's about more about what the healthcare provider
yeah,
at wherever they're at, has available to
yeah,
be able to treat the patient, right? Yeah, I mean, but see, all of that is really good information to have.
correct.
This is just me speaking. You're right. You do not want to get in a habit pattern or whatever of getting so many different treatment options and prolonging treatment for a long time because you certainly don't. I mean, treatment is your friend.
Yeah,
You need treatment, but you do need to make the best decision possible for your particular disease, particular makeup of your tumor, that kind of thing. I almost feel like sometimes 3, and then you're going to know. You're going to know.
Yeah.
You're going to know where what you should be doing. And so anyway,
There's maybe also, if I may, another thought about that is
please.
there's life to live, correct? And so I'm the first person to love enroll patients into a clinical trial, but does it make sense? Does it make sense to travel 6 hours every day for a clinical trial? Unless this is like a game changer,
Right.
maybe not. But that's a little bit also where the conversation with the patient comes into place. It's like, okay, this is your situation. This is what we can offer. How can we make this fit? And having, for example, and that's also, I think, something that's unmet need in our field is to have patients do their assessments more at home, like the MRI scans and the lab draws and all that, instead of coming to the centers that offer the trial. But these are more philosophical approaches. But I think that there has to be a good conversation about what can be done and what should be done.
Right. And you're right. The patient does need to make a decision.
Yeah.
And it is about quality of life. It has to be an informed decision, though. That's the thing, is you don't want patients making a decision without the information that is rightfully theirs to have.
Yeah.
And so, yes. And so I really liked what you just said. Wouldn't it be wonderful if patients could have like basically their lab work done at home, some other things? I don't want to get off the topic, but what do you think about decentralized clinical trials?
Well, we're playing around with this because, obviously the pandemic has changed a lot. Telemedicine finally has arrived. How we take care of patients. Patients also don't want to leave home. During the pandemic, they didn't have to do it. So why now? But that's the idea, to kind of think about new ways of delivering care. And so sometimes there has to be a physical interaction. But we try to design our trials in a way that we build that in. Actually, for example, again, this is not PCNSL lymphoma, but in glioblastomas, having radiation locally makes a big difference because that's a daily thing. As long as there are like basic things covered about the dosing and the schedule and things like that.
Right.
But I think that is where this is having. Well, I hope that is the direction that we're all heading. Yeah.
I hope so too. I do. I have a little bit of a question. It's sort of related. MSK stands for
Memorial Sloan Kettering Cancer Center.
yes,
Yes.
in New York City.
Oh, actually, we have satellites in New Jersey and in New York State.
So you have the Rockefeller Outpatient Pavilion.
Yep.
In New York.
Manhattan, yep.
Manhattan, okay. Where at in New Jersey?
So we have in the south of New Jersey, which is Monmouth, which is at where the beach is out.
Yeah.
Then Baskin Ridge, which is kind of like more, not central New Jersey, but it's more towards the center. And then Bergen County, which is in the north of New Jersey. Then we have Westchester, which is not upstate New York, but for New Yorkers or Manhattaners, this is upstate New York. And we have Long Island location.
Oh, you have Long Island. I didn't know that. I didn't know that. So then the natural question then is awesome. And the question then is, at these satellite offices, if we're talking about PCNSL, what is available to them at the satellite places that you mentioned?
Well, not me personally, but I unfortunately only see patients at the moment in the city at our Coke facility and in 53rd Street Rockefeller Outpatient Pavilion. But we have neuro-oncologists and neuro-oncologists that treat and see primary CNS lymphoma in all our satellite facilities. And we design our clinical trials in a way that patients can receive the trial treatment in these locations. Some of them we
Fantastic.
can't do detailed pharmacodynamic and pharmacokinetic testing, but we're working on these things. But yeah, no, these recurrent refractory trials are all open. The first line, not because methotrexate is only given in the hospital in the main city, but they can receive portions of their treatment in the satellites. Patients like that because
Y-
parking is easier and
Yes,
it's much better.
yes,
Yeah.
yes. Patients really like that.
Yeah.
Yeah. And so do the neuro-oncologists who are at those satellite sites, do they all get together for tumor boards to discuss a patient case kind of on a weekly basis, that kind of thing? Okay.
Yep.
Maybe talk about that just a little bit if you would.
Yeah, so actually a lot of those neuro-oncologists having sites in Manhattan and the satellites. So because of the, I see mainly CNS lymphomas, and so there's a lot of lymphoma doctors in the city. So, that's why there's a lot of referrals, and that's why the space needed to be in the city. But it can be that within the next 1 or 2 or 3 years, I also have a satellite office. It's just very fluent, and it's not like I don't know how it is in other institutions, but when there is a label that says MSK, it is MSK doctors and not, the labeling out. So it's the same doctors and the same standards, and these doctors rotate. Or have seeing patients in the city or in the satellites. Same trainings, they all come together. It's the same department. They do research even, themselves with their own protocols. And so I then see their patients in the city when they're in the city. So it's kind of like my extended arms. My patients go to these facilities, get their treatment. I can even see them when they're in the location as a telemedicine visit because, I just touch base with them that way. It's very nimble because, again, it's to make sure that patients get access and get their treatment done and don't have to travel to the city.
That is fantastic. I mean, that works well for everybody. It's less, what's the right word? Rigid?
Yeah.
It's, yeah. So that's great. That's really
Oh, yeah.
great. Do
Yeah.
people know that, or is that just something that they ask about or they find out about, I guess, when they're diagnosed, or, you know, i- is that, you know what I mean?
Yeah.
Does MS
Yeah.
do a great job getting that information out there?
I think then they don't know it immediately, but they learn very quickly because they
Okay.
are. I see
Okay.
someone here or there, and it's people also travel. They have their weekend home in Long Island and they live in the city.
That's
So
true.
yeah,
That's true, actually. That is great because you know what? That's increasing patient access,
yeah,
which is the core, that increasing patient access and increasing patient treatment options is at the very core of what you're doing, and increasing patient quality of life and survivorship. So amazing, amazing work. So we are in the challenges and unmet needs session. You've talked a lot about a couple of things I wanted to talk about, and you definitely talked about access to experienced centers earlier on in this interview. Is there anything else you want to add to that particular topic?
access. Well, again, I think it all boils to try to get a second opinion. And Yeah, if you have a rare disease, you want to go to a place with rare diseases. Same thing with if you have a complicated surgery, you want to go to the surgeon that does it every day instead of the surgeon that does it once a year.
Agree.
I think that is the idea. Or if it's not possible physically to do that, then at least have someone who is experienced in that field guide your local team or work with your local team. And I think that helps, patient outcomes, patient access, and yeah, don't be afraid of asking questions. That is another thing. Very important.
Very key important. Don't be afraid of your healthcare team.
Yeah.
it's okay to ask questions. It's okay to be concerned. It's okay. You're not going to offend them. They want you to ask questions. They want you to be comfortable with them. They want to hear from you. It is a partnership. And the more communication, the better. And the more communication leads to better outcomes. So this is just my suggestion out there to all of those patients and families and care partners who will see this. Do ask the questions. Never be afraid to ask a question. Every single question is very, very important to you, and therefore you should ask it.
Correct.
Um,
And the burden should not be on the patient to decide if it's an important question or not.
every question is important. Every question is important. So, what do you see, Dr. Grommes, as gaps in care and research for the PCNSL community?
Well, again, I think the problem is in cities, in larger cities, you have centers of excellence, and in rural areas, this is more difficult to get to. That's one. Access to clinical trials is obviously limited. If you don't go to a specialized center, even a specialized center might not have a trial in PCNSL. And so it's also it's challenging because it's a neurologic disease with a cancer that not a lot of neuro-oncologists treat. And so finding the expertise and the trials is, I think, the most problematic thing. Also, we're facing a more and more elderly patient population, so we will see more of promising.
Yeah, so maybe we could talk about that just a little more. You have talked about we are seeing an aging population with more, of course, we're seeing a larger aging population, and so we're seeing more people being diagnosed with PCNSL who are older. So that brings up a topic, which is the need for better and less toxic treatment options, less toxic therapies. So that is important for patients to understand, is that there is work going on in that area. Just think if you could take a pill instead of having to be admitted for 3 to 5 days wherever you're at for treatment for PCNSL. Just think about that. There are advancements coming in this particular disease that should be easier for patients, including our older patient population, to utilize.
Yep, there are trials ongoing for that. That's right. But you also have to keep in mind that whenever you change a treatment that has the potential for a cure, then you have to be very careful. Because you don't want to miss that chance that the patient has. So, but yeah, that's the idea, to reduce the toxicity of the treatment, the problems that come with being admitted and all that, to a more easier treatment. But that treatment needs to be safe, and that's what we're working on.
That is definitely. In working with PCNSL patients and their care partners, they have shared with the End Brain Cancer Initiative that one of the things that they would like to see when diagnosed is much more information given to them on their diagnosis and also on the potential, the treatment options and the potential treatment options, clinical trials, things like that. How do you, as a physician, researcher, how do you move that kind of what I guess is a real unmet need? How do you move that forward?
Well, we do a lot of patient education already. So it's not only me that talks about it, it's the nurse practitioners that are in the inpatient setting. We have a pharmacist in the in and outpatient setting that is there to educate patients about their treatments and therapies and side effects. So there's a constant ongoing, repeated education about the regimen, the chemotherapies, the side effects, what to look out for. And again, these patients are in the hospital every 2 weeks, so this is an ongoing education of the family and the patients, and it gets very routine after a while for them because they got that education. But that's what it's all about: it's the communication, education, the constant reminder. What are the side effects? What we're looking for? And so, yeah, I think that is the way to overcome that lack of knowledge.
Do these patients and or their care partners receive a survey related to what they might perceive as an unmet need or perceive as an amazing need that was filled?
That's a good question. I'm not sure they get a survey for a particular that. They get a survey for, the hospital stay and the care, and
Yes.
but not in particular like, ooh, what are the things that you want to have more information about?
Okay.
Well, it's a good idea, actually.
That's a great idea.
Yeah.
And I know that we have some of that information. We did a survey. And so the one of my very we're getting to where we're going to wrap this up. I'm curious because I do not know the answer to this question. Does MSK have a support group for the PCNSL community?
And not in particular for the PCNSL community, but for brain tumor.
But they have a brain tumor.
Yeah.
Okay. So the PCNSL community would be included in that. Okay. Do you know, is that like a monthly thing or?
Yeah, I think it's a monthly theme. Yes.
Yeah.
A social worker does run that, actually.
When you have a moment, would you mind emailing me that information or even just an introduction to that social worker? I would really like to talk to her about that, and I certainly would want to make sure patients knew about that and their care partners.
Mhm.
That sounds good. Okay.
Yep.
So, hey, we're wrapping things up. Is there any last thoughts or comments you would like to share with our audience?
Well, I'm blessed working with promising lymphoma patients because I do, we generally have a more upbeat vibe in our clinic because people get better, they do better, they have follow-ups without any, changes on the MRI scan, patients are in remission. So it's just a different patient population. And so, we always say when you have a brain tumor lesion, we always hope that it's a promising lymphoma versus a glioma because we have more options and we can do more. But yeah, it's still a rare disease, still a little bit of an unmet need and to improve on. But yeah, I think it's an exciting time to be in promising lymphoma research too, because there's a slew of new treatments and treatment options that will come down the road that we can apply to our patients.
That will be very exciting. That's that completely exciting. And I know that we'll probably get to talk about some of that more in depth. I know there's probably going to be some other opportunities where we'll get to do something similar to this, where we can actually talk really specifically about that and those potential treatment options. And that's, that's education. And that's so exciting as well. So that's wonderful. What was that? I'm so sorry.
I would be happy to do that. Yes.
Oh, good. Oh, I have to talk to you then. I just wanted to actually add another comment that a patient wrote, if I may.
Oh, yeah.
Dr. Grommes and his staff is the very best in the business. Always excellent and so experienced. I mean, that's so fantastic. I did appreciate what you said, that your clinic is kind of upbeat and kind of, I'm not sure I can say that about a lot of clinics that I've been into. So,
But yeah, but it's even if you have a high-grade glioma, this is an anxiety introducing situation. So trying to ease that situation, that experience for our patients helps. again, I like to offer options and choices, no matter where we are in the journey of a patient. And I think that also helps to ease a little bit the anxiety to say, oh, at least, we have something to talk about. I might not be able to offer a lot of treatment options, but we still have, support options for symptoms and things like that. And
Absolutely.
there is, I think seeing this, if I feel nihilistic, then my patients feel that immediately, and that's not what I should do.
Well, I appreciate your and your team's philosophy, because you're absolutely correct. This disease is hard.
Yeah.
And anytime you can make a patient or their family or their care partner smile while they're also in for a consult or treatment, wow.
Yeah.
That's actually part of the treatment.
That
You
is
know,
correct. Yeah.
it really, really is. It's very special that you do that. And I promise the next time I'm in New York to come by and say hi.
That would be nice.
Um,
Yeah.
yeah, I've been to MSK, but it's been a few years. But it's, now I have a reason to go back. So this is really great. Dr. Grommes, thank you so very, very much for spending time with us today. And your knowledge is exceptional. And you have just helped so many people understand this disease, like the general public, but you've also helped that entire PCNSL community understand more about this disease, as well as the treatment options. And so I thank you very, very much. We just don't get enough opportunity to create these wonderful opportunities of education. And so I value your expertise and your time so very much. So thank you. And we will add in a graphic that has your contact information. We'll approve it with you first. And then we'll add in a graphic that also has contact information for the In Brain Cancer Initiative's patient navigator as well, because we can help get you to those whatever centers of excellence, right, in the PCNSL area, and get you those second opinions that Dr. Grommes did speak about. So here working for everyone as a team for this patient population. And it is an honor to serve the PCNSL patient population. So thank you for allowing us to also do that in partnership.
Well,
Thank,
thanks for having me. Thank you so much.
thank you so much. Have a great rest of your day.